Let's now talk about the common clinical features or signs and symptoms of with which a patient with essential thrombocytosis will present to us. One important thing to understand is essential thrombocytosis or essential thrombocythemia. They are effectively the same term, so these can be used interchangeably as well. In patients with essential thrombocytosis, there can be two or three major pictures. A lot of patients are asymptomatic and they are accidentally discovered on the CBC examination. And when you have compared it with the previous CBC reporting, you will find a consistent or a small increase in platelets which was unnoticed previously. In the patients who present with symptoms, the symptoms can either be of hemorrhagic picture or it can be a thrombotic picture. The hemorrhagic picture is because the platelet count is, although the platelet count is increased, but the platelets are not functional. Most of the platelets are because of an increase. It is basically a mutation in the JAK2 pathway, which leads to an increased differentiation of the megakaryocytes. And this can lead to a large number of platelet in the peripheral blood film, but most of these patient platelets can be ineffective, which don't have the granules to cause normal coagulation. This hemorrhagic picture is more evident in cases in which we have a very large increase in the platelet count, like the platelet counts in millions. Most of those cases have a hemorrhagic picture. And what are the common types of hemorrhages that a patient with essential thrombocytosis can present with? Well, they will have easy bruising. For example, any smaller cut can lead to an increase in the bruising. The GIT symptoms can be very much evident with GI hemorrhage. Hematemesis or melena can be evident in the form of hematemesis or melena. A small cut can lead to a large number of bleed. It can be a minor spleen bleeding as well. The gums bleeding, eyes, the retinal hemorrhages are very common presentations in these patients. Urinary tract presentation in the form of hematuria. So any patients with any of these symptoms, which is unexplained on the basis of other pathologies, you should have essential thrombocytosis or any other cause of thrombocytosis in the back of your mind to arrive at a differential diagnosis. And similarly, it can also present in the form of joints and brain hemorrhages. It can cause a hemorrhagic stroke or it can cause hemarthrosis. Contrary to that, if we have a thrombotic picture with the platelet counts being increased, then it can cause pooling of the blood. It will interfere with the flow of the normal blood. So we might have an increased tendency of thrombosis in these patients as well. This is evident mostly on the platelets count, which is generally less than 1 million. So they can have a lot of functional platelets in them and they can lead to thrombosis of the arteriolar and the venous circulation. So we might have a picture of erythromelalgia, which is basically painful digits. This is the same term which we used when we were describing polycythemia vera. So erythromelalgia, which is basically a symptom of both these disorders, polycythemia vera and essential thrombocytosis. Similarly, with the disruption of the blood supply to the brain, we can have ocular migraines in these patients. We can have orbital pain in these patients as well. Similarly, the occlusion of the blood supply to the important arterial circulation can lead to transient ischemic attacks or stroke, thrombotic strokes, ischemic strokes in these patients. So the patient with essential thrombocytosis can effectively present with a hemorrhagic stroke, or he can also present with a thrombotic stroke, depending on which picture is predominant in what kind of a patient. Continuing on with the thrombotic tendencies, the patients can have occlusion of the legs, the coronary and the renal arteries. So these patients can present with a leg or calf pain. They can also present with, in rare cases, with angina or myocardial infarction. They might have a renal failure picture in some types of patients. Certain types of venous thrombosis can also be evident, like the splenic, hepatic, or the leg and pelvic veins. So we might have an unexplained DVT in a patient who doesn't have any other issue, or we might have a minor variant of a Budd-Chiari syndrome. Budd-Chiari syndrome is most commonly in the polycythemia vera patients, but they can also be present rarely in patients if the venous thrombus is large enough to cause the occlusion. Other types of venous thrombi can also be present, which lead to a lot of problems. For example, in the pulmonary circulation, the thrombus can lead to an increase in the pulmonary capillary pressure or the pulmonary hypertension. So all of these features of pulmonary hypertension will be present. So as you can see that either the patients, around 40 to 50% of the patients do not present to us with any other symptom. When they do present to us, the symptoms are very non-specific. You can't pinpoint a specific presenting clinical feature or presenting symptom that can point out to the direction of definitively to the essential thrombocytosis. So you have to look at the overall clinical picture and use your clinical judgment. To aid with that, the physical examination, a few of the patients have splenomegaly. Splenomegaly is not a very classical sign of patients presenting with essential thrombocytosis. Splenomegaly is more commonly present in polycythemia vera or primary myelofibrosis. So if you have a patient with splenomegaly and increase in the platelet count, that does not mean that the patient has essential thrombocytosis. You have to first rule out the other types of myeloproliferative disorders. Similarly, rarely patients can also have hepatomegaly. So as you can see that the physical examinations don't really help us so much, but they are just there to make you aware of the fact that if you have a patient with splenomegaly and those patients do not fall under the criteria of polycythemia vera or primary myelofibrosis, then you have to keep essential thrombocytosis very high up in the list of your differential diagnosis.